The video got disconnected. So they were asking about the region, right? Uh, the case was of IV drug abusers, and the bacteria was Staph aureus, and that was presented with septic embolization to the lungs, right? So the option A, option B, option C, option D. They are asking about the location, right? That that would be most commonly affected in IV drug abused by Staph aureus, like this one or this one. So they have respective options, like option A for this, option B for this, option C for this, option D for this. So pause and give the answer. The correct answer for this question is option C, right? Because it is the location of tricuspid valve. Let us see to the explanation. So the correct answer is option C. Okay. So these are different areas over here. We can hear hear different sounds. Okay. So this one, the first one is the second intercostal space on the right side. And this one on the left side, again second intercostal space. Then this is the third intercostal space. Okay. Then if we go down, sorry, this is also again the second intercostal space, right? And if we go down over here, this one is the fifth intercostal space, right? um, and this one again, the fifth intercostal space, it met clavicular line. So these points are important to be noted, right? Okay. So in the second intercostal space on the right side, if there is aortic regurgitation, right, from root dilation, that would cause diastolic murmur. But if there is aortic stenosis, right, that would produce systolic murmur. Let me give you one important explanation for this. Let's say if the let's say we have two types of valves. One is this one, tricuspid valve between right and right atria and right ventricle. Then we have mitral valve between left atria and left ventricle. Then we have semilunar valves like pulmonic valve and aortic valve. Okay, if in case of these semilunar valves, if there is uh, regurgitation, right? If there is regurgitation, that would produce diastolic type murmur, right? But if there is stenosis, right? If there is stenosis in case of pulmonic valve, that would produce systolic murmur, right? If there is regurgitation, that would produce diastolic murmur. If there is stenosis, like aortic stenosis or pulmonic stenosis, that would produce what? Systolic murmur. But this is opposite to the case of these valves, mitral and the tricuspid valve and mitral valve. Over here, what would happen if there is uh, regurgitation, like tricuspid regurgitation, that would produce systolic murmur, right? But if here is uh, tricuspid stenosis, right, that would produce diastolic murmur. Same over here. If here is a mitral regurgitation, that would produce systolic murmur. If there is mitral stenosis, that would produce diastolic murmur. Simple, right? Okay. So, as I mentioned, this is the aortic area, second intercostal space on the right side. This is the pulmonic area, second intercostal space on the left side. So, if there is aortic regurgitation, that will produce diastolic murmur. If there is stenosis, aortic stenosis, that will produce systolic murmur, right? Okay. Now, on the left side, this is called pulmonic area. If there is pulmonic stenosis, as I mentioned, right, that will produce what? Systolic murmur. Same. Also, over here we can uh, heard the sound of ASD, atrial septal defect, right? Point to be noted. Then we have on the same location, if we have like pulmonic regurgitation, right? Pulmonic regurgitation, then that would produce diastolic type of murmur. Same, just like that, because it is similar one. Okay. Then if there is let me go down. Okay. If there is aortic regurgitation from which is of valvular type, but it is, regurgitation, right? Regurgitation that would produce diastolic murmur, right? What it would produce? It would produce diastolic murmur. Okay, but this one is valvular type, so it would be on the left side, and EBA was from root dilation, that is on the right side. Okay, now if there is hypertrophic cardiomyopathy, right, that would produce systolic murmur, right? Point to be noted. Okay, now if we came to the fifth intercostal space on the left lower sternal bar above, like in this case these are upper sternal bar, they are located, they can be best heard at upper sternal bar, over here at upper sternal bar, but if we come over here we can best hear it in the lower sternal bar. Okay, so if there is tricuspid stenosis, as I mentioned, if there will be stenosis in the above walls, that would produce diastolic murmur. If there is regurgitation, right, if there is regurgitation, that would produce what? Systolic murmur in case of tricuspid or mitral valve. But this is the location of tricuspid valve, this is the location of mitral uh, heart sounds. Okay, and this is called mitral area, right? And this is located at the apex of the heart. Okay, okay, so mitral stenosis, diastolic murmur. If there is mitral regurgitation, that would produce systolic murmur. If there is mitral valve prolapse, that would produce systolic murmur. And if there is VSD, that is also located, that heart can be best heard in the tricuspid valve area. Okay, now one point which you should to be noted is let me go this ASD, then we have VSD, and then we have mitral valve prolapse, right? They all produce systolic type of murmur, but we will go one by one location. Like in pulmonic valve, we would hear ASD sound. Then in tricuspid area, we would hear VSD sound, which is both are systolic. When we go down in the on the same fifth intercostal, in the same fifth intercostal space, but at the apex, mitral valve prolapse, right? Okay. So the cavitary pulmonary nodules on this patient chest X-ray are consistent with septic emboli, which are common complication of right-sided infective endocarditis. Tricuspid valve is frequently affected in IV drug users. Bacterial adherence may be encouraged by inadvertent injection of particulate matter that damages the tricuspid valve endothelium. Staph aureus is the most common organism responsible for infective endocarditis in IV drug users. A murmur of infective endocarditis typically results from regurgitation of blood due to impaired closure of the affected valve. Although tricuspid valve endocarditis doesn't always cause a murmur, in early or hollow systolic murmur of tricuspid regurgitation. Point to be noted. If it is regurgitation, that will produce systolic murmur, right? Okay, is sometimes appreciated. This murmur is best auscultated in fourth or fifth intercostal space. Point to be noted. Left lower sternal border, as I mentioned, left lower sternal border, the tricuspid auscultation area, and it increases in intensity with maneuvers that increase right ventricular blood volume. For example, inspiration and supine leg raise. With this, it would increase what? It would increase the murmur sound. Let's say, let me explain this for you guys. Over here, if there is tricuspid valve problem, right, and if we are increasing more stroke volume, venous return, then stroke volume would be increased, right? Then we are increasing more pressure on this area, so this is not good for these damaged walls. So is these walls are already damaged, so it will further increase the murmur sound. So increase inspiration, and with that supine leg raise, they will increase uh, venous return. With that, it would increase stroke volume, so it would increase burden on those damaged walls. Okay, why not option A and D? Most aortic valve murmurs are best auscultated in the second intercostal space on the right upper sternal border. Mitral valve murmurs are best escalated at the cardiac apex, which is usually located in the midclavicular line, important left fifth intercostal space. Okay. If infective endocarditis affecting these left-sided heart walls may cause septic embolization, but point to be noted, to the kidneys, brain, or other systemic organ, but not to the pulmonary circulation. This is important. Okay. Then why not option B? Okay. Why not option B? The pulmonic valve murmurs are best auscultated in the second intercostal space in the at the left upper sternal border, right? Infective endocarditis affecting the pulmonic wall can occur in IV drug users and lead to septic pulmonary emboli, but it is far less common than tricuspid valve endocarditis. Let me draw this for you guys so that it could be easy for you. Here, let's say on the left side we have aortic wall, on the right side we have pulmonic wall. So there is crossing of the sound, like the aortic sound would be transferred to the right side of the heart in the second intercostal space. The pulmonic would become convert would be transferred to the uh, left side, right, in the second intercostal space. Okay. So infective endocarditis in IV drug users commonly affect the tricuspid valve, often leading to septic pulmonary emboli. Patients can have an early or holosystolic murmur of tricuspid regurgitation, best auscultated in the fourth or fifth intercostal space at the left lower sternal border. So in question number 31, a 56-year-old man is evaluated for fatigue and dyspnea and exertion. Okay. Past medical history includes hypertension and systemic sclerosis, right? BP is 135 by 80 mm of mercury. Pulse is 68 per minute. Cardiac examination reveals loud second heart sounds with no murmurs. Lungs are clear to auscultation. Further evaluation with catheterization procedure is performed, okay, during which a balloon tipped catheter is advanced into the pulmonary artery. A branch of pulmonary artery is occluded by the balloon, okay, and the pressure beyond the point of occlusion is measured. Okay, they are asking about pressure beyond the occlusion. Okay, the pressure reading from the procedure most likely correspond to which of the following options, of which of the following pressures. So they have given different pressures, like left atrial pressure, right right atrial pressure, then pulse pressure, right, and with that they have given different options. So the correct answer for this is, because I have opted it correct one, this is left atrial pressure, right? Because let's say if this is the heart, okay, over here, they are moving from here over here, then they will go to the pulmonary artery, right? Then we know the pressure from here till that, till the left atrium, the pressure is same, right? That's why they are saying that the pressure beyond the point of occlusion is, which is measured, is of left atria, right? So they have given different options: intra pressure, left atrial pressure, mean airway pressure, mean arterial pressure, pulse pressure, right atrial pressure, right ventricular pressure. So pulmonary artery catheters, that is PSCs, also called Swan guns or right heart catheters, are used to diagnose pulmonary hypertension and occasionally for management of critically ill patients. During pulmonary artery catheterization, the balloon at the distal tip of the catheter is inflated and the catheter is advanced forward to the right atrium, then right ventricle, then pulmonary artery, and finally into the branch of pulmonary artery. Right? Once lodged in a pulmonary artery branch, the inflated balloon obstructs forward blood flow, right? Creating a continuous static column of blood between the catheter tip and the left atrium, right? The pressure measured at the catheter tip at this time is called pulmonary arterial occlusion pressure, PAB, right? Or pulmonary capillary wedge pressure, right? PCWP. and closely reflects left atrial and left ventricular end diastolic pressures. That's why I did selected left atrial pressure, right? Okay. Why not option A and C? Direct measurement of intrapleural pressure, that is called pleural manometry, can be obtained by placing a catheter in the pleural space during thoracentesis, right? When we are aspirating fluid from the thoracic, right? That is called thoracentesis. Okay. Whereas mean airway pressure is measured during mechanical ventilation, right? Pulmonary arterial catheters do not measure intrapleural or mean airway pressures, right? Why not option D? Mean arterial pressure is measured by placing an arterial catheter directly in the central arterial circulation, the common femoral or radial artery, and reflects the average aortic pressure, perfusion pressure, right? Okay. Why not option E? The pulse pressure refers to the difference between systemic arterial, systolic and diastolic BP, right? Okay. Why not option F and G? Right atrial and right ventricular systolic pressure can be measured directly by pulmonary arterial catheters by placing the catheter in their respective chambers, right? So pulmonary artery occlusion pressure is measured at the distal tip of the pulmonary artery catheter after an inflated balloon occludes blood flow to the pulmonary artery branch. It closely corresponds to the left atrial and the left ventricular end diastolic pressure. The next question is, a 56-year-old man is brought to the emergency department due to sudden onset severe chest pain. BP is 88 by 56 in Mafeji. Pulse is 83 per minute. On physical examination, the patient is in moderate distress. The jugular veins are distended. No murmurs or extra heart sounds are heard on cardiac auscultation. The lungs are clear to auscultation. ECG shows evidence of ST segment elevation, myocardial infarction. Bedside echocardiography reveals contractile dysfunction of large portion of the right ventricle. Point to be noted. And normal function of entire left ventricle. Entire ventricle is normal, right? With myocardial infarction involving only the right ventricle. Again, they are pointing to one important point. Okay, percutaneous coronary intervention with coronary angiography is performed and shows thrombotic occlusion affecting one of the major coronary arteries. No other significant atherosclerotic lesions are identified. Which of the following most likely explains the findings in this patient? Okay, occluded artery with that coronary artery dominance. Option A, LAD and with left dominant. Option B, LAD with right dominant. Option C, left circumflex with left dominant. Option D, left circumflex with right dominant. Option E, right coronary with left dominant. Option F, right coronary with right dominant. Right? So the correct answer for this question is, okay, pause it and give the answer. The correct answer is option F. Why? Because the problem is of right heart side. Okay, right side heart. With that, it is like they are saying that the left heart is normal. Okay, so it is the right dominant. Okay, because the right coronary artery is supplying the PDA in most of the patients, right? No, this couldn't be the right dominant, because if it were right dominant, right, then it would supply PDA, right, and is PDA is involving the inferior, the posterior aspect of the left ventricle. But they are saying the left ventricle is good, is normal, so it couldn't be this option, right? So as we know, the right coronary artery is already involved, but as we know, they are saying the left ventricle is normal. So if we look to the case of left dominant, right, what would here the left circumflex would supply the PDA, right? Is they are saying that the left ventricle is normal, that means left circumflex is normal. So this is the left dominant. So the correct answer for this question is not option F, right? This is option E. Yeah. So the coronary circulation is composed of three major epicardial vessels: LAD, right, left anterior descending artery, arises from the left main coronary arteries and courses down the interior heart. Okay, supplies the interior left ventricular wall and septum. Right. Okay. Then we have left circumflex that would supply the lateral wall of the left ventricle, right? Okay, so left circumflex arteries arise from the left main coronary artery. Okay, course is around the left side of the heart. Okay, supply the lateral wall, lateral left ventricular wall, as I talked about this. Okay, occasionally left circumflex extends all the way around the heart to supply the inferior left ventricular wall. That is in the case of left dominance, as I was talking about this, right? The right coronary artery, RCA, comes directly off the aorta and courses around the right side of the heart and supplies the right ventricle. Okay, in most patients, RCA extends past the right ventricle to also supply the inferior left ventricular wall. That is the example of right dominance. Okay, blood supply to the inferior left ventricular wall depends on the coronary artery dominance, right? Right coronary dominance is present in approximately 85% of patients, right? Okay, and involves the RCA, okay, coursing past the right ventricle to give off the PDA, posterior descending artery. That would RCA would give branch to PDA, okay, and supply the inferior left ventricular wall. Left coronary dominance is present in approximately 10% of patients and involve the left circumflex extending around the left side of the heart to give off the PDA and supply the inferior left ventricular wall. Okay, approximately 5% of patients have codominant circulation. Okay, in virtually all patients, the right ventricle is fully supplied by RCA, right? And in patients with left dominant circulation, none of the inferior left ventricular wall is supplied by RCA. Therefore, isolated right ventricular myocardial infarction can occur due to RCA occlusion. Okay, in patient with left dominant circulation. Okay, if there is right coronary artery involved and that is left dominant circulation, right? given the given the low prevalence of left dominant circulation, isolated right ventricular mi is an uncommon event, approximately 3% of a myocardial infarction. So it is less common, but they have mentioned this just for checking your knowledge. Okay, why not option A, B, C, and D? The LAD and left lateral circumflex do not supply the right ventricle and are not involved in the right ventricular MI. Okay, why not option F? With right dominant circulation, the RCA supplies the inferior left ventricular wall. Therefore, RCA occlusion would cause MI involving the right ventricle and the inferior left ventricular wall. This is important. Okay, are the inferior left ventricular wall alone if the occlusion is distal to right ventricle. So the blood supply to the inferior left ventricular wall is determined by coronary dominance. Most patients have right dominant circulation, in which the inferior left ventricular wall is supplied by right coronary artery. Approximately 10% of patients have left dominant circulation, in which the inferior left ventricular wall is supplied by the left circumflex artery. The right ventricle is fully supplied by the right coronary artery in virtually all patients. Okay? Now, in question number 33, we have a 52-year-old man comes to the office due to chronic cough for the last 3 weeks. The patient says, I haven't been coughing off plagium, but sometimes I notice some blood on the tissue. When I cough particularly hard, he has smoked 2 packs of cigarettes daily for the past 30 years and drinks 4 cans of beer on weekends. He works as a welder on an assembly line and says his father died of lung cancer at age 70. Physical examination shows this is important. Point to be noted. Right sided face and arm swelling and engorgement of subcutaneous veins on the same side of the neck. Important are these points, okay? Which of the following veins is most likely obstructed in this patient? Option A, axillary; B, brachiocephalic; option C, external jugular; option D, internal jugular; option E, subclavian; option F, superior vena cava. So pause it and give the answer. So the correct answer for this question is brachiocephalic. Why? Let us see to the explanation. This patient has symptoms consistent with obstructed right brachiocephalic that denominate vein, right? Let me show this for you guys so that it could be easy for you guys. Okay, so let's say this one is the brachiocephalic vein, right? And this is the right subclavian vein, and this one, okay, and these are the jugular veins, right? Which are supplying, uh, which are taking the uh, are draining the fluid from the face area, okay. And with that, like, we have the subclavian vein, which are draining the fluid lymph from the arms and shoulder area, okay. So they are saying that obstructed right brachiocephalic innominate vein, right? Okay, this may be a result of external compression by an apical lung tumor, or thrombotic occlusion is can occur when a central catheter has been in place for an extended period. Okay, the right brachiocephalic vein, since they were presenting, the history of his father with lung cancer. Okay, so the right brachiocephalic vein is formed by the union of the right subclavian vein and the right internal jugular vein. Okay, as I mentioned that there will be right internal jugular vein with that. If I want to show you this one over here, this is subclavian vein, and this one over here is the right internal jugular vein. Okay, so the right external jugular vein drains into the right subclavian vein. So obstruction of the right brachiocephalic vein will also cause venous congestion of structures drained by the external jugular vein. They mean to say over here this one, right? As I mentioned, this one is the internal jugular vein. This one is the external jugular vein, and this one is the um, right subclavian vein. So this external jugular vein is first draining into the right subclavian vein. Then these both internal jugular vein with that the right subclavian vein, they drain into the brachiocephalic vein, right? And then this one, left brachiocephalic vein and the right brachiocephalic vein, they will drain into the superior vena cava, right? Good. So it is it is important to note that the right brachiocephalic vein also drains the right lymphatic duct, which drains lymph from the right upper extremity, right face, neck, right hemithorax, and right upper quadrant of the abdomen. Why not option A and E? The subclavian vein is the continuation of axillary vein. Both drain blood from the upper extremity. Blockage at any of these two sides would cause unilateral arm swelling, important arm swelling, without associated facial swelling, because that is associated with jugular vein, right? That would be associated with jugular vein problems. One option C and D. The external jugular vein drains the scalp and portion of the lateral face. The internal jugular vein drains the brain and superficial face and neck. Obstruction of the internal jugular vein would not cause arm swelling, just like opposite of the above case, right? Because the arm is not drained by these veins. Okay, why not option F? The superior vena cava syndrome results when the superior vena cava is obstructed. The signs and symptoms of superior vena cava syndrome are similar to those of obstructed right brachiocephalic innominate vein, except that both sides of the face, neck, and chest and both arms would be involved, right? Because as we mentioned, that if let's say this is the right brachiocephalic vein, if this is the left brachiocephalic, they both will drain into the superior vena cava, right? So both face, neck, arm on the left side, face, neck, arm, all will be affected, right? So the brachiocephalic vein drains ipsilateral jugular vein and subclavian vein. The bilateral brachiocephalic veins combine to form superior vena cava. Brachiocephalic vein obstruction causes symptoms similar to those seen in superior vena cava syndrome, but only on one side of the body, right? Okay, this is the last and final question for this cardiac anatomy session, right? We have a 58-year-old man with a history of hypertension, hyperlipidemia, comes to the emergency department due to substernal chest pain, began 6 hours ago, gradually worsened. BP is 104 by 72 mm of mercury, pulse is 88. Not important. Okay, all these things. ECG shows normal sinus rhythm. Okay. ST segment depression, T wave inversion, troponin levels are elevated. Okay. This patient is diagnosed with non-ST segment elevation MI, that is NSTEMI, and admitted to the hospital for medical management with coronary angiography scheduled the following morning. Okay. The evening, sorry, that evening, telemetry monitoring shows new Mobet's type 1 second degree AV block. This is important. AV block. Which of the following arteries was most likely obstructed during this patient MI? Okay, since this MI has been result from AV block, we would find the artery which is supplying AV node. Okay, so options are LAD, left circumflex, left main coronary artery, ramus intermedius, right coronary artery. Pause it and give the answer. The correct answer for this question is right coronary artery. Why? Because this is supplied by right coronary artery. Okay, but point to be noted, if let's say this patient, if the patient was of left dominance, because this AV node and SA node, these are supplied by a dominant one, right? uh, in case of right dominant, right, this is supplied by RCA, right? But in case of left dominant patient, that would be the case of left circumflex. Yeah, because that would be supplied by this. Okay, good. So left, so low degree AV block, including first degree and Mobet's type 1 second degree, usually involves conduction disruption within the AV node. This patient's development of Mobet's type 1 second degree AV block in the setting of acute MI suggests obstruction of the right coronary artery. In approximately 90% of patients, RCA supplies blood to the AV node while coursing around the right side of the heart to perfuse the right ventricle and inferior portion of the left ventricle, right? Because the RCA also usually supplies blood to the SN node. Sinus bradycardia is also commonly seen with MI involving the RCA. Okay, in contrast, the LED artery, which courses down the interior left ventricle, typically supplies blood to the left and right bundle branches, sometimes the bundle of Hess. MI involving, okay, now this is important, right? LED supplying these things, left, right bundle branches with that bundle of Hess. But RCA was supplying SA node and AV node. Yeah. MI involving the LAD can lead to high degree AV block. For example, Mobet's type 2 second degree block, infranodal third degree block. Okay. Involving conduction disruption below the AV node. Okay. Because the LAD doesn't supply blood to the AV node, low degree AV block is not typically seen. Okay, why not option B and C? The left main coronary artery bifurcates into the LAD, that is left anterior descending artery, with that left circumflex artery, which would supply The left side of the heart, lateral wall of the left ventricle, which courses around the left side of the heart. Okay, it supplies the lateral left ventricle. The left main coronary artery doesn't directly supply blood to the conduction system. The left circumflex artery frequently supplies blood to the SA node after coursing around to the back of the heart, but only supplies the AV node in about 10% of the patients, those with left dominant coronary circulation, about which I was talking. This is came in MCQ, right? Okay. Wine adoption D, present in approximately 20% of the population. Ramus intermedius is the third branch of left main coronary artery, originates in the bifurcation of the LAD and left circumflex, courses between them and supply the anterior lateral left ventricular wall. Doesn't supply blood to the conduction system. Okay. So low grade AV block, like first degree, Mobet step 1 second degree, involves conduction disruption within the AV node. The occurrence of low grade AV block in setting of myocardial infarction suggests obstruction of the right coronary artery because it supplies the blood to the AV node in approximately 90% of the patients. So enjoy this block. And if you find any problem, you can comment us, you can ask freely. Thank you. Bye bye.